Forum. I'm Claudia Curry-Hill, and I'm the moderator for today's panel. I would like to introduce you to our Center Without Walls program panelists. The Center Without Walls program is funded by the Race to Erase MS and has provided support that has permitted the medical community to link together multidisciplinary scientific programs and expertise across the country to advance the understanding of the cause of MS and to develop new treatments. The center is a breakthrough success because of the vision, insight, and flexibility of these extraordinary doctors. Dr. Liliane Amazuka from USC, Dr. Peter Calabrese, Johns Hopkins, Dr. Ann Cross, Washington University, Dr. Andrew Goodman, University of Rochester, Dr. David Hafler, Yale, Dr. Adam Kaplan, Johns Hopkins, Dr. Jonathan Santoro, USC, Dr. Nancy Saikat, Cedars-Sinai, Dr. Rhonda Vashko, UCLA, Dr. Emmanuel Wabant, our Race to Erase MS Medical Director from UCSF, Dr. Howard Weiner, Harvard, Dr. Vijay Yadav, Oregon Health Sciences, and our founder of the Race to Erase MS, Nancy Davis. I'm going to introduce Nancy now to kick off our panel discussion.
Hi, everybody. Welcome to what is now our 27th annual Race to Erase MS. Last night, we hosted actually an in-person event, which was pretty amazing. We've always had an event every year. It got postponed from May till September, and we were glad that we could do sort of a drive-in to Erase MS, a very COVID-safe type of an event. And we want to let everybody know that we are very committed, no matter what, to raising money. Just we've gotten so far with this research, and we need to keep raising money. It's so important, more so now than for any time, as we look at diseases like COVID coming in, and knowing that people with MS are definitely in that group that has to be more isolated and more worried about their health. We would like nothing more than to make people with MS not have to be in that particular group of people that is more at risk when a disease like COVID, or who knows what else might come in the future. We had pretty much had a banner year. There's so many new findings, and I'm excited today for all the doctors to talk about the new drugs that have gotten FDA approval recently, and to really understand what they are, and to understand how COVID has affected MS and what the risks are for everybody. I'm really committed to doing this. I myself have MS. I've had it for 28 years now. I'm probably the luckiest person who's living with MS. I'm doing really, really well. I don't take the traditional medicines, but I'm doing everything I can to keep myself as safe as I possibly can. And I'm just very committed to finding a cure. Last night at our event, we honored my son, Jason Davis, who passed away 6 months ago. He died from a double pulmonary embolism. It might have been that he had one of the earliest cases of COVID, and that was some cause of it. We don't know, but we honored him. He'd always worked very hard on Race to Erase MS, and it was something he was so passionate about finding a cure for. So it was really my pleasure to be able to honor him last night. It's been a rough 6 months for so many people's lives. We also last night were able to receive an amazing award that will help somebody from the Red Songbird Foundation, somebody who suffers from either depression or addiction, who has MS. And we're going to open that up to giving a scholarship to somebody in my son Jason's name to help them get treatment, which is going to be a lovely thing, and we'll hopefully grow on that in the future. With our wonderful group of doctors. They have been with us for a long time. They are amazing, and I know this year has been very challenging for every one of these doctors to do their thing. They have all been on these amazing webinars. They're out there giving everybody great advice. They're on the forefront getting data from all over the world. It's really impressive to see how everybody's just going as fast as they can, getting every possible bit of information to help people understand COVID and everything, and still coming up with medications and different things that are really helping people with MS. So I want to congratulate our whole panel and thank you for what you're doing. And I want to thank everybody who's donating to Race to Erase MS. It could never be more important than it is now to really find a cure for MS. So thank you so much, and thank you for listening in today.
Thank you, Nancy. Our first topic is COVID-19 and MS. And here with the latest figures and data is Dr. Ann Cross from Washington University.
Thank you, Claudia, and I just want to thank you all and tell you how happy I am to be involved with Race to Erase MS. I mean, I'm really impressed with this organization. It's clearly been a very bad year. I'm going to show you some data, and I will share my screen now. And hopefully be able to put it on. There we go. So I guess it was close to 6 months ago now that a number of people realized that we needed to have a registry of people with MS across the world, but certainly across North America, to try to figure out if there's any special thing about MS that might make people with MS have maybe not do as well with it if they were to get COVID-19, and also just to look at the different disease modifying therapies, since so many of them affect the immune system, and how they might relate to the outcomes if people were to get COVID-19. So my colleague Amber Salter, whose picture's on the next slide, along with a number of different people, put together a registry which is housed out of Washington University, where I am. And it's a registry intended for healthcare professionals to put in data about people who developed COVID-19 or were infected, perhaps asymptomatically, with SARS-CoV-2 virus. And the idea was to make it as easy as possible for the busy healthcare professional to put the data in. The request was that data not be put in until at least 7 days had gone by since the person had developed the disease or been tested positive, and to make sure that sufficient time had gone by such that we could see what would happen to that person, and everything is de-identified. So this is Dr. Amber Salter. She's quite young, as you can tell from this picture, and she is an assistant professor of biostatistics at Washington University, where I am, and she is the main driver of this. And I would like to mention this caveat, which is that these registry data are almost surely biased by reporter knowledge. That is, that clinicians who learn about people that they may take care of who have MS, who developed COVID-19, are probably more likely to hear about the bad outcomes than those that are good. And I can attest to that myself, because just seeing patients, I sometimes will hear about the fact that they had lab tested positive COVID-19 and did quite well, and so they didn't bother to call me several months ago. So this data is probably skewed toward the bad. So our data right now, so we actually collect from neuromyelitis optica and myelin oligodendrocyte glycoprotein antibody disorder. These are two diseases that are similar to MS, but not the same. And most of the results I'm going to tell you about today will pertain only to MS, but I just thought I'd mention that. We're actually over 900 MS cases as of this morning, but I put these slides together about a week ago, so these data are as of August 28th. Our registry contains mostly people from the United States, a few from Canada, a few from Mexico, a few from Puerto Rico, a few from Caribbean islands. And the vast majority, of course, are people with multiple sclerosis. The gender breakdown is exactly what you would expect for MS, 75 to 25 female to male. And we are collecting from all, racial groups, and the Hispanic community is well represented in the list. So these are the states where we obtain data. All these that are dark blue like this, we don't have any data on anybody yet from those states. We have, interestingly, data coming in from over 150 different healthcare providers, which makes us feel much better about the data. We were concerned that it would be primarily from academic centers, but it looks like it's coming from all over. The biggest states, of course, are New York and New Jersey that have entered data so far. Not surprising, but California and Florida are not too far behind. So from now on, I'm going to present you data just pertaining to multiple sclerosis or clinically isolated syndrome. And 99.2% of the people in this, what I'll present to you, are confirmed multiple sclerosis. The mean age is 48. The racial breakdown is 66% white, 26% Black or African American, 0.5% Native Hawaiian or Pacific Islander, 0.8% Asian, a number of people who are unknown race, and then 14% Hispanic or Latino. These are symptoms that people have reported, people who had MS, and note a couple of things. One is that we have about 5% or more of people tested positive, but were asymptomatic. So that means that MS is certainly compatible with having asymptomatic disease. Only 60% of people had a fever. And in fact, one of my patients I spoke to the other day was telling me that she took her temperature every single day and she hasn't had a fever yet, but she has lab tested positive COVID. So screening for fever is good, but it doesn't catch everyone. And so the other symptoms that people have complained about are pretty much what you hear about in the general population. The breakdown of people are pretty similar to what you would expect for MS in general. 77% relapsing remitting, 15% secondary progressive, 5% primary progressive MS, perhaps a little low there. 84% were taking disease-modifying therapy. Most of the people are laboratory tested positive, which I think is good for this information because it makes it more valid. And we've had a number of people, you know, a large percentage who visited emergency rooms or were hospitalized, and a few deaths. And I'll get into that a little bit more here. This is a slide comparing MS deaths. There have been 47. That's been holding steady for the last couple of weeks. We haven't had a single other death for quite some number of days despite rising numbers. So that's very comforting, I think. We have 51 total deaths in the registry. The other 4 are all neuromyelitis optica. It's interesting some of the differences you will see between those that died, the 47 and 771 alive. Now, the reason why this doesn't add up to our total is because there were a few cases where the person who entered the data didn't actually comment whether people were alive or dead, so we couldn't include them here. But you can see that people who were alive tended a little bit more to be female than male, whereas the skew was more toward male, which is like in the general population. The age was greater for those who died and lesser for those who remained alive after developing COVID-19. The duration of disease was shorter for those who made it through, and those who were fully ambulatory, 75% versus 14% amongst those that died. So, and the other big thing that was different is those that died had a much higher rate of comorbidities, and I'll get into that a little bit later too. Here is data on the disease-modifying therapies, which is what everyone really, cares about. And I want to just point out a couple of things. Well, one is that we have no denominators here, so you have to sort of take this with a caveat. What we've used as a semi-quasi denominator is the market share for each of these drugs. And one thing that has popped out and remained true throughout is that amongst the people who developed COVID-19 itself and those who died, there has been a very low proportion of people on the old platform therapies versus the market share in the country. But again, this may be skewed by the fact that it could be that the practices that are entering their patients here are not using the older platform agents as much. But we have been intrigued by it because interferon beta has actually been used in some therapies, and we don't know yet if it'll be effective, but it's used in some trials for COVID-19. Here are comorbidities, which I mentioned. So these are the general comorbidities that we asked about in the registry, and the reason is because these are the ones that were associated with bad outcomes in the general population. And of interest here is that there was a much higher rate of comorbidities in those people who died, just like in the general population. And those who died were 6 times more likely to have 3, 4, or 5 separate comorbidities. That would be down in here compared to those who made it through. So these comorbidities, hypertension, cardiovascular disease, diabetes, morbid obesity, etc., were associated with a bad outcome. But we did not see a statistical association of cigarette use with a bad outcome, although there was a trend. So I'm going to talk a little bit more about the bad outcomes. And again, the caveat is that we probably hear more about bad outcomes than we do good outcomes, and they get put into the registry. So these data are data that were put together by Dr. Salter, and she did statistical analyses comparing outcomes for mortality alone, mortality or ICU admission, or mortality, ICU admission, or hospitalization, since we thankfully didn't have that much mortality, using multivariate logistic regression data, so taking into account the different covariates that are known to be associated with disease. And so here, the primary thing to see is that older age and being non-ambulatory, so wheelchair bound, were associated with poorer outcomes. So being non-ambulatory versus being fully ambulatory, and fully ambulatory here means not using a cane or walker, was across the board associated with better outcomes, or worse outcomes if you were non-ambulatory. Worse outcomes if you were older, and for every 10 years of age, there was an increase in worse outcomes. Again, not different from the general population. And being male versus female was associated with worse outcomes. And then one little trend toward maybe worse outcomes for hospitalization, primarily with being on an anti-CD20 agent versus the other disease-modifying therapies. So again, I would just want to say that these registry data are likely biased by the knowledge of the clinicians about bad outcomes more than good outcomes, and also by the fact that we have no denominators. So I'm just thank all the people that I work with here in St. Louis, which gets a bad rap in the press, but it's really a nice city. And we're working to make it better. So these are our group at the John Trotter MS Center at Washington University and Barnes Jewish Hospital. Thanks a lot for listening. We'll keep adding data and updating as we can.
Thank you, Dr. Cross. And next, COVID-19 and disease-modifying therapies, stay the course, discontinue or change, Dr. Emmanuel Wabant and Dr. Nancy Sykott.
Thank you.
I will let Dr. Sykott start.
Thank you, Dr. Wabant, and thank you, Claudia, for the introduction. And just want to say first, congratulations, Nancy, on an amazing night last night. And this is our second virtual panel, and it's great to see all our colleagues together. I also want to thank Dr. Cross for that presentation, which really is the key to helping us make good decisions for our patients, and that is data. And I really have to say that one of the silver linings of the pandemic has been the way that the scientific community has come together across the world. And we hear a lot about divisions and people fighting with each other, but I think the MS community has really come together to try, and the medical community in general, to try and understand the pandemic, and that allows us to have real data and work together to do the best for our patients, which ultimately is what our goal is. And Dr. Wabant's going to talk a little bit, I think, about IWIMS, which is her initiative that turned out to be very timely in allowing us to have a forum to gather data and share data on a regular basis during the COVID pandemic. But I was going to start just by talking a little bit about, you know, what I experienced as a clinician and what we've been, how our thinking has evolved as the pandemic has worn on, and what we've learned, and what patients should be thinking about and asking their neurologist about. So I guess I'd like to take us back to the very, very beginning when we started thinking about the fact that this virus was going to make it onto the shores here in the US. And I have to say that I think our MS patients were prescient. They're very much taking care of themselves and looking out for possible risks associated with infections and so forth. And I started getting calls pretty early on from concerned patients about what they should be doing and should they be worried. And certainly, given that we are dealing with an autoimmune disease and individuals are on disease-modifying therapies that affect immune function, there was a lot of concern in the beginning that MS patients would be uniquely vulnerable to the infection and possibly bad outcomes. So I think at the very beginning, there was a lot of information that was put out kind of sort of before we had any data. And there was a lot of discussion about changing medications, stopping medications. And these were based on the best sort of guess at that point, based on what we knew about other infections or other autoimmune or disease-modifying therapies. But I think it's really important to emphasize that without data, we really are making these recommendations sort of in a vacuum. So with a brand new virus, a lot of unknowns, we really were trying to balance the risks, potential risks of having the infection when you're on a therapy versus the risk of disease progression. And so I think we're trying to balance that risk benefit always. So, you know, in the beginning, what many of us were worried about is for therapies that involved, you know, going to an infusion center, for example, that this could be a risk that patients felt uncomfortable about. So some of the infusion therapies, individuals were deciding that they were going to hold off on doing their treatments. And this can be an issue, especially for medications that have the potential for what we call a rebound effect, such as natalizumab or Tysabri. So stopping things precipitously can actually end up causing a risk for developing, you know, new activity. So it's really a nuanced discussion, I think, that we have to have with our patients and thinking about the risks and the benefits of keeping on their medications, switching to something else, or stopping altogether. And so what we've learned so far, as you saw in the data that Dr. Cross was presenting, is that overall, individuals who have MS don't appear to be any more or less likely to get infected with COVID, in keeping with the fact that none of us are immune to the virus. And that overall, the risk of developing severe disease is related to those comorbidities that we also have identified in non-MS patients. So hypertension, diabetes, obesity, and older age. These are the main risk factors associated with a poor outcome. So I think the last factor, and this has required more time to accumulate data, that is the disease-modifying therapies themselves. Are there different medications that are either better or worse in terms of outcomes with COVID? And I think we're starting to get enough information now to really make some recommendations in the sense that interferon therapy seems to be associated with a lower risk in terms of infection or bad outcome. And the anti-CD20 medications, that would include rituximab and ocrelizumab, do seem to have some data suggesting that outcomes are more severe in individuals who are treated with that medication. And that comes from data that Dr. Cross has presented, also from information from the Italian group, paper that is in press or recently published, and then also from data from Sweden that showed a lot of the patients who ended up in the hospital were on rituximab. So this really raises some interesting and difficult conversations to have with patients regarding what's the best treatment, what's the best decision going forward. And I would also offer that it's even more complicated as we anticipate that we may have a vaccine. And so as we know, and the immunologists in the group will be able to speak to specifically, anti-CD20 medications are affecting B cells, and B cells are the cells that are activated when you have a vaccination. And so one of the thoughts that we have to kind of come to grips with, I think, is thinking about timing of those treatments in relation to the potential of having a vaccine. So I've actually started these conversations with patients as we think about if their next infusion, holding off on their next infusion, for example, thinking that we may have a vaccine by the end of the year. And what's really striking to me, and I think is going to require a lot of work, is that many of my patients who otherwise would take vaccines, who usually get their flu shot, are saying right now that they will not take a vaccine for COVID if it's available. I think this is a big mistake. And I think that it's also speaks to some of the other ongoing issues that we're having in the medical community. So I want to leave time for my colleague, Dr. Wabant, to talk more about how the international community has come together and also get her take on some of these really interesting and evolving issues. But my final word for patients who are wondering what's the best thing to do, definitely have a conversation with your neurologist. Think it through, because it's a very individual decision based on your disease activity, based on your age, other factors. And I guess also I'd say stay safe, wear your mask, and we'll get through this. So Dr. Wabant.
Yeah, so that's a great overview. Thank you, Dr. Sykott. And I would say wash your hands also, the additional recommendation. So a few months ago, as Dr. Sykott said, we were concerned because there was no clear data on which we could rest some of the treatment recommendations we would have for patients. And we have started a collaborative group called the International Women in MS that actually was holding calls every week and then every 2 weeks with physicians working at MS clinics from all over the world. And what that has enabled to do was really to share in real time some of the information that was coming out. As you know, the peak of the pandemic reached countries like Italy, Spain, and France before it reached the US. And we could learn from our colleagues in Europe, actually, about what they were seeing. And as Dr. Sykott alluded to, there was data from different databases, like the data Dr. Cross just presented, that became available from Spain, from Italy, a little bit from Germany, a little bit from Sweden and France. And all the different databases have a different structure and are collecting information in ways that can bring different answers to questions. And it's really looking at the puzzle of data that's outside that can help us try to put things together and understand what's happening. So at this point, most of the databases are based on physicians reporting cases, but some are also patients reporting their infection, like the data coming from UK. And that has helped overall to understand, as Dr. Sykott mentioned, that MS does not seem to be a risk factor to get the infection with COVID. And it's also not a risk factor in itself. So it's not considered the comorbidities. Often my patients are asking, is having MS a comorbidity increasing the severity of COVID-19 infection? And that's really not what we have seen. The data that Dr. Cross has showed is that, and that has been confirmed in other databases, is that mostly comorbidities like in the general population, like cardiovascular, diabetes, but also age, were major risk factors. The slight difference, I would say, with MS is that patients with higher disability are actually patients with a risk of worse outcome. Now, when we look at whether treatments are neutral in terms of increasing or decreasing the risk of infection, Dr. Sykott alluded to the fact that there's a couple of registries now that are suggesting that being on treatment such as interferon may in fact decrease the risk of infection. And so that's something that's interesting, because now we understand fairly well the biological pathways that the virus takes to actually create the symptoms that occur with COVID-19, and definitely interferon is an important one. But then there are several medications across different registries that seem to be neutral. And by neutral, I mean medications that don't increase the risk of infection and medications that do not seem to be associated with a worse outcome for patients infected. And that would definitely include medication like Gilenya, Tecfidera, Tysabri, interferon, and Copaxone. Or medications within those families of medications. There's been a question mark, but now several registries are pointing to the possibility that medications such as rituximab or ocrelizumab, Ocrevus, may increase the risk of infection by a little bit, and for patients who develop the infection may increase the risk of a severe outcome. So this has been seen in different registries. That's why that signal is possibly real. It does not prevent us from using those medications. We just need to be more careful. Different physicians have had different strategies. I think that because of what has been seen, the longer the treatment with those medications, apparently the higher the risk of a severe outcome. So for patients who just started, it doesn't look like there's really a change in the risk. It comes for patients who have been on these medications for a longer period of time. So what we're doing, we're still using these medications because we think that these medications work really well, and for some patients, they really make a huge difference in their prognosis. But we need to be more careful when we use those medications. And I'll conclude on the use of pulse steroids. So from the Italian study, it seems that having received a high dose of steroids like we use to help to shorten the duration of MS relapses may actually be associated with an increased risk of a bad outcome with COVID-19 infection if the steroids have been received a month before the infection. So again, very precious information in terms of how it guides physicians to decide, yes, I will give a pulse of steroids, or no, I will hold for giving steroids now because I don't think they will make a difference. So we have to customize treatment to individuals, and it's really key to talk with your doctor. So I'll end up there. And thank you, Nancy, for a great event yesterday. And thank you for allowing us to share this information timely with patients, because we're even talking about data that have not been published yet. And the MS community nationally, but also internationally, has been incredible in their generosity sharing data together, because there was a strong unity in the group, understanding that sharing was really key to treat our patients better.
Thank you, doctors. And next, we're going to talk about social isolation, depression, and anxiety during coronavirus and MS. Dr. Adam Kaplan.
Thank you so much, Claudia. And again, thank you, Nancy, we wouldn't be here without you. So I'm going to start with just sort of outlining the problem and who's particularly at risk of the mental health fallout, and then give some ideas and even, I think, a wonderful example of how to overcome these problems. So first of all, as of this morning, and I'm going to round off a little bit, in the United States, there were 6 million people infected, 190,000 deaths. And to put that into perspective, it's now the third leading cause of death. COVID-19 is the third leading cause of death, and it beats deaths due to accidents, motor vehicle accidents, crossing the street and stuff like that. It's 3.5 times already the number of deaths due to influenza. So this is a major problem, and there is something to be worried about. So, it's not just bury your head in the sand. And we know that it's having a fallout. So there was a large, this group, the Mental Health of America, does screens. They've done 5.5 million screens of people in this country in the past 6 years. They registered a 400% increase in the rates of depression and anxiety going on in the United States. Not surprising given what has been going on. There is a Canadian study just out September 1st that confirmed this, What I think an important take-home message, though, is that the group that is most affected are people less than 25 years of age. Also people who may not be getting the kind of support and check-ins that they might. And it makes a huge difference as to how the different groups respond. So for instance, if you're living at home and you're in an older age group, that's protective against anxiety and depression. If you're young, but when you should be out of the house, that's actually a big risk factor. So it's person specific. What are the contributors? What are the things that matter? Well, loneliness and isolation, and we know from past pandemics that these are major issues. Grief or loss, knowing people who have been affected. Financial concerns, because there's huge financial fallout, unemployment, etc. Stigma, which goes hand in hand with racism in that this has become a major issue for this country. And in fact, when things are looked at, there is a similarity in a sense that people who are double stigmatized, people who are from minority populations have an increased risk. It's interesting not to see that in some of the data, but generally an increased risk of poor outcomes. And then if you have the infection, everybody tends to be afraid of you. So this is a major issue. And the other major thing is, and this has been a big problem, so trying to get this from clinicians or people in your life, what tends to be protective is getting a clear message that is consistent, reliable, and reassuring from a trusted source. That has also been something that we have been lacking, I think. So the important thing to know, though, is that the groups to be particularly aware of, we are all vulnerable, but are people less than the age of 25. People with pre-existing psychiatric histories or depression and anxiety being among the big ones. And to my fellow panelists, healthcare providers. So healthcare providers are terrible at seeking help. And so we should all learn from what we're going to try to teach our patients that, being on the front line, handling patients going through this, it's very difficult. So what do I recommend? Well, I'm a simple guy, I like simple solutions. So I think of, the ABCs of how to handle this. So the first A is for ask for assistance. That knowing how to ask for help is far more important than just being able to demonstrate that you can silently endure in pain. And it actually takes more strength. People think, oh, I'm going to be really strong and I'm going to suck it up. It takes more strength to reach out a hand and ask for help when you need it than it does to sort of ignore the need that you have for someone else. So asking for help also, remember, gives other people a chance to help you. So not only are you cutting yourself off from getting the help you need, but you're cutting other people off from being able to help you. B is for breaks. Give yourself a break. You're not going to respond as you normally would under all circumstances. There will be more irritability, more anxiousness, and the like. Give yourself a break. This is not life under usual circumstances. And also take a break. Remember, at least once a day, you need to check in with yourself. You need to, do mindfulness, meditation, or just read something that will give yourself a chance to just breathe and take a break. C is for communicate. And now that we're all isolated with people we care about, little things that weren't a problem before that led to stepping on each other's toes become a big problem. And so if you don't make it explicit that this bothers you or that this is something you'd like more of, then you're communicating with your body language and actually having arguments about other things not related to the real problem. So try to communicate directly. D is for don't do things that will make it worse. Don't self-medicate with alcohol, drugs. Be mindful of the fact that if you wouldn't do it before COVID and not going to do it after, now's not a good time to start. The E is for exercise. Exercise, eating right, and sleep, keeping those going is very important. F is for finding purpose and making time for fun in your life. G is for gratitude. Positive psychology has shown that if just once a day you think of something that you're grateful for, despite everything that's going on, it actually it decreases your chances of depression and improves your outcome. So the one thing I'm just going to close with is to tell everybody out there, presumably people who have MS or have family members with MS, is that you've been through a crisis before with a very unpredictable disease. So when you were first diagnosed, you didn't know whether there'd be another attack. You didn't know what the treatment was. You didn't know when you'd get out of this acute situation where you knew nothing about this illness. So remember, you have tackled an unpredictable foe and met the challenge. And so remember what you've learned and use those skills, and remember to teach other people. Now, I think the three things that a dear friend of mine who has MS taught me is, in approaching MS, the three things are: first, accept the problem, accept that this is what you're battling. Second is adapt, and then the third is to achieve. So the best example I can give of this is Nancy Davis. So this year, Nancy was confronted with, the impact of COVID, and it was going to blow out of the water her chances of having, her annual gala. But she, rather than ignore what was going on in terms of the COVID, she actually accepted that this was a problem. She then adapted, and she and Liz and all of the people who work for the foundation pulled together, and they achieved an amazing accomplishment last night. So I think that if no one else you could think of Nancy as someone who has accepted, adapt, and achieved. And this is the kind of thing that I encourage everybody to realize. You have the ability, you have experience, draw on that. Thanks very much.
Thank you, Dr. Kaplan. And next we have Staying Well with MS, Staying at Home and Going Out, with Dr. Vijay Yadav and Dr. Liliana Amazuka.
Thanks, Claudia. Thanks, Nancy, for putting this forum together. And I mean, I agree with Adam completely, learning from this experience this year, which has been so hard on so many people, that you are able to put this program together, do this, the fundraising also so successfully. I think it's truly inspirational. So thank you so much for your efforts that you do all the time, and especially for educating people in this time when we are all sort of bombarded with negative news all the time, to try a positive kind of feel to the patient that yes, we can do it. I think you are truly inspirational that way. So really thank you to you for inspiring all of us. And then coming back to the topic that we were given about staying well with MS, as well as in this COVID era, what we should be doing. So I think I would like to probably focus more on the diet and how to eat well, and impact of the comorbid conditions, how we can manage those at home or going outside. And then Dr. Emezua will talk about how we can keep ourselves more healthy by exercising and those aspects. So my research interest has always been in looking into diet and comorbid conditions, but I think during COVID it became even more important to realize that the people with MS or without MS, people who were getting affected by COVID were unfortunately those people who were not as healthy. So their bodies were not as healthy, so that they did not really have as good immune system to really tackle the impact of this novel virus, that caused so much of damage. So diseases such as hypertension, cardiovascular disease, diabetes, even obesity, all of them are lifestyle related. Most of them are lifestyle related, especially with diet and exercise being the big kind of cofactors. So what we have learned so far from the database that Dr. Ankos presented, the impact of these diseases on the morbidity as well as mortality in MS patients or elsewhere needs to be addressed very actively. So while we were all confined inside our homes, we are all at home right now, giving this webinar, and so are you, most of you are. So I think staying at home has added few, I mean, it's challenging, but so I think it has given opportunities. At the same time, it has been challenging as well. The opportunities are that extra time that we now have of not commuting to work or not going outside can be utilized to improve your own health. So, and I think eating, frankly, is probably one of the big things that we can do. The food, I feel, is really important in tackling all of these comorbid conditions, maybe improving the, weight, while, sitting at home probably made us gain some weight, but I think we need to become much more cognizant that if we focus on those aspects of health by eating well, eating high quality food, and not just feeling bad that, we are by ourselves, we don't really have any help. So I think it's an active process that we have to be involved with, actively looking for things that we can do to keep ourselves healthy. Another thing that I thought should be probably addressed is like, which Dr. MS will focus upon, is while you're at home, breathing exercise, because pre-morbid conditions such as lung problems was also one of the factors for increased mortality or increased complications due to COVID. So things like yoga or breathing exercises, I think if you do it on a regular basis, can be extremely helpful for dealing with COVID complications. So far, thankfully, our MS patients have behaved very similar to the general population. So we are hoping that we will do well and keep ourselves much more healthy despite staying at home, despite having the challenges of this pandemic that we are dealing with right now. So I think with that, I would like to give it to Dr. MS Guha.
Well, again, I do want to start with saying thank you to Nancy for bringing us together, and again for an excellent event last night that just reminded me how much passion, perseverance, and resilience you have. And again, thank you for having me. I am just going to practically continue and just reminding everyone about the 3 W's. Basically, how do we stay well now that most everything is in many places reopening? Of course, different places with different restrictions, but I do believe in the 3 W's. Basically is wear your mask, wash your hands, watch your distance. And I think last night was a great example that that can be done. And socializing is certainly going to be something that we need to do. And so what can also, on top of all the ABCDEs that Dr. Kaplan mentioned, can we do? Well, certainly exercise is really important apart from the diet and controlling those comorbidities. And I do feel that in these past several months, apart from, having these discussions with our patients about DMT, I have practically paid so much more attention than ever before on those comorbidities if they do exist, and making sure that they are well controlled and not getting out of hand. So how do we maintain healthy? Well, yes, apart from the effects, the positive effects of exercise on maintaining a good weight, I do think it, and there's enough evidence to support that it also gives you a good mental state, diminishes anxiety, prevents depression, and so how can we maintain that if most of the time one is at home? Well, I think it has, there's in the past several months, there became much more available online exercises that could be done, yoga, Pilates. There's a lot of places that are now having these sessions outside while maintaining a distance, so that can certainly be looked for. The other is that we can also try to find out if physical therapy is available in your area. Here in Southern California, for us, or at least at our center, our physical therapists are active and open, not fully capacity, but we can get our patients in, or we can safely have physical therapy go and see the patient because it's rather important to maintain movement and preventing deconditioning, which is what we have seen a lot in these last 3 months. So certainly that needs to be watched for, and because that can certainly increase spasticity and of course affect the motor ability. But certainly if you're experiencing much more worsening inability to ambulate, one needs to reach your doctor. And also don't be afraid to reaching your doctor. Like we said, most of us are having telemedicine, so we are available to speak to you and evaluate you and now safely bring you in. Of course, we try to avoid high-risk areas, which are considered to be hospitals or crowded areas, but with all the different restrictions that have been made, those areas are usually now safe. So one last thing that I do want to mention from the apart from the exercise is the issue of vitamin D. Vitamin D, we know, is rather important in MS in so many ways. It is an important supplement. We know just in MS itself that having lower vitamin D levels can be associated with high risk of clinical and radiological breakthrough, and that just vitamin D level is also a well-known risk factor for MS. But what do we know about vitamin D and COVID-19? Well, there's a lot of observational data that is emerging, and even from the past, that we know that vitamin D has the ability to at least decrease or prevent just viral upper respiratory infections. And so from those observations, there's been a lot of thought looking at just COVID-19. There's just a recent study that just came out yesterday in JAMA from the University of Chicago, noting, again, it's an observational study, but noting that those that tend to have lower vitamin D levels, and in this case, the people that are more likely to have low vitamin D levels are individuals of race, African-American background, even healthcare workers, those in nursing homes. And what they found was that they were more likely to have worse outcomes with COVID-19. There's a lot of thought that you know, vitamin D is not just a vitamin, but it's the known thought that we know that it modulates the immune system, particularly perhaps preventing the inflammatory cytokines from going array like it's seen with COVID-19. So I would say that apart from your exercise and vitamin, just take a good vitamin D level, make sure that you are getting your vitamin D supplementation and levels checked as recommended by your doctor. And remember, again, those 3 W's: wear your mask, wash your hands, and watch your distance. Thank you.
Thank you, doctors. And next, immune response to COVID-19 infection and development of vaccine for coronavirus, Dr. David Hafler.
Okay. Thank you, Claudia. And again, thank you, Nancy, for the absolutely terrific job you did in organizing the Race to Race MS last night. It was just absolutely terrific. So I'm going to briefly talk about immune responses to COVID and the vaccine and try to put it in the context somewhat of the research that the center has been doing in terms of multiple sclerosis, because it's all clinical immunology, and one studying the virus has in fact given us insight into some of the basic immunology of autoimmune diseases. So first, the point made earlier, the scientific community has really come together in investigating COVID. As we've all generated research and data goes immediately into the public domain, even before publication. And it's really changing the nature how we do scientific work. At Yale, we have what's called the HIP-C grant, the Human Immunology Project Consortium grant, which I'm principal investigator on. And much of the early NIH funding went through the HIP-C grants in order to investigate some of the mechanism of how the virus inducing disease. And it turns out that the virus induces an interferon response, a type 1 interferon response. And you've all heard of interferons. Interferon beta has been a longstanding treatment for MS. And curiously, there's almost a perfect correlation between the viral load, that is how much virus you're exposed to, in relationship to the type 1 interferon signature. And that may relate somewhat to the very intriguing data that was presented by Anne, suggesting that maybe being on interferon may be somewhat protective. So early on, you have this effect of type 1 interferons, which are fighting off the virus. But then shortly, within a week or so, in a subset of individuals, you have a hyperimmune response that leads to attacking the lung and primarily the heart. I must say we've not seen any virus in the brain or central nervous system when we've looked, but clearly the virus can affect the lungs and the heart. And in fact, one of the genes that is involved with risk of MS is associated with the immune response that's going on in the lung. And one potential immunotherapeutic approach is to block that receptor interaction. But the immune cells reacting to the virus go into the lungs. And in a small set of individuals, there's a hyperimmune response, something called a cytokine storm, which can lead to profound damage to the lungs and occasionally to the heart. So by investigating COVID, we've actually been able to learn a fair amount about the immune system, and some of it relates to MS. And one last point, which we're investigating now, are some of the long-term consequences of COVID infection. We know that not an insignificant number of patients develop nervous system problems, including depression. And we know that administering type 1 interference in patients with MS and others causes depression. So we're now investigating whether or not the interferon induced by the virus may be related to some of the depression. So end with a discussion about vaccination. I don't have any more insight than many of you, but I'll give a few comments. First of all, I wouldn't expect a vaccine by November 3rd. Let's be realistic. This is unlikely. The vaccines trials have started, are in phase 3. They require 2 dosing. And in fact, as reported in the Wall Street Journal today, the number of the drug companies, Moderna, AstraZeneca, Pfizer, Sanofi, have put together a pledge that they will not seek approval for a virus until all of the safety issues have been addressed. And so it's going to be critical for everyone to take the vaccine. It's not going to be released. The medical community is not going to let it be released until we're sure that it's safe. But it's absolutely critical that once the vaccine's available, if it's efficacious, that it won't work. A vaccine doesn't work unless people take it. So having a vaccine, but if the population doesn't take it, one's going to be we're going to be in be problems. You've also may have heard in the lay press about the antibody test. Well, why is it that the antibodies seem to go down with time? And does that mean there's not long-lived protection? No, it doesn't mean that. We know that a significant part of the immune response to the virus mediated by T cells. So in order to get an antibody response, you have memory T cells, which are induced with infection or will be induced with a vaccination. And so when one is re-exposed to the virus, the T cells will rapidly trigger a B cell response. So the fact the antibodies go down really doesn't provide any information. Now, will the vaccine work? As my grandmother would say, from your mouth to God's ears. We don't know. But every indication to date, even the Russian vaccine was reported in Lancet yesterday, that the vaccine induces an immune response to the virus. And the immune response that is induced by the virus appears to be as good as the natural immune response that one sees. So there's every reason to believe that the vaccine will work, and I'll bet my bottom nickel that it will work. What I don't know is how long will the vaccine work for? Will it work for 20 years, 10 years, 5 years, 5 months, 5 weeks? That is what we don't know. But I wouldn't be discouraged. There are a few reports of individuals who had the infection, one strain, they were able to be reinfected. There have been millions of people infected. We're bound to see that occasionally, but by and large, everything suggests to date that the vaccine should work. And time will tell as to how long it will last, whether we need redosing every year, as with the flu vaccine, but probably not, because the virus doesn't seem to mutate as much as a flu vaccine. I'd strongly encourage everyone to get a flu vaccination. This is going to be absolutely critical in being able to differentiate between COVID and flu. So please make sure you get, every MS patient should absolutely get a flu vaccine this year. I think that's very important. I'll end with one other interesting point about the testing. I won't make any political comments about how frequent we should be testing or lack of testing that's gone on. But just to point out that one thing that's emerging with the testing is what the cutoff is. So when you work in the laboratory, obviously right now the test for the PCR, we measure the active virus, comes back as positive and negative. But every laboratory has a different cutoff as to positive and negative. So I'm very curious, I'd like to talk to Ann later in terms of the MS data, is when we look at positive or negative, do we have the actual values, the so-called delta CT values? Because we're finding that if you go to the lowest detectable measure of virus, that it's not that useful. And you really need to know exactly how much virus is there. And at Yale, we decided last week that rather than just reporting positive, negative, we're going to report the actual values so that physicians can evaluate what the real viral load is, because it's the viral load that's important. So the bottom line is, I said earlier, eat well, wear your mask, wash your hands, do social isolation or social ineptness, whatever we're calling it now. But if you do that and are careful, we should all remain safe until there's a vaccine, which I'm quite confident will be available come the end of the year by early winter. And hopefully we'll be able to get the US and everyone vaccinated by spring of next year. We can go back to normal. So thank you.
Thank you, Dr. Hafler. Now we're on to our next topic, what's new in MS? And we're here to talk about recently approved MS therapies is Dr. Andrew Goodman.
Well, thank you, Claudia. And I'd first like to thank Nancy and her team for the remarkable achievement of putting on last night's gala. It's so absolutely critical to the mission of this organization. And also thank you for putting on this forum in such a safe and convenient way for all of us. So my thanks, as others on the panel have said. So Nancy last night in her introductory remarks, I think framed the situation quite well, despite the awful pandemic that we're living through. A lot has happened in MS, and we shouldn't ignore it. So I'm just going to briefly go over what's happened in the past 12 months in terms of new therapies that have been actually approved by the FDA. Starting back in October, a drug called diroximel fumarate, which is called by the brand name Vumerity, was approved by the FDA. So this is an alternative formulation, an oral formulation of the older drug Tecfidera. In the clinical trials, it was similar to Tecfidera in its effectiveness, but reported fewer problems for patients with the gastrointestinal symptoms that are commonly seen when people are initiating Tecfidera. A couple of months later, in December of 2019, the FDA approved actually 3 different versions, generic versions of fingolimod, which is known as Gilenya, which has been approved for the past 10 years. And these are capsules, as many of you will know, that are also a convenient oral treatment for people with MS. I'll just jump to August. Another generic drug, generic version of Tecfidera was actually approved in August. And the hope for added value of generic drugs being approved is to lower the cost and increase the accessibility for people with MS. And obviously we all hope that that's true. It should be remembered that these generic drugs also carry the same benefits, but also the same risks as the brand name. So we shouldn't ignore that fact. And likewise with Vumerity, which is actually so similar, to Tecfidera, that we have to remember it also will carry the same risks. In March, right in the middle of the COVID-19 lockdown, frankly, a new drug was approved called Zeposia. The generic name for this is ozanimod. And this is in the same family of medications, the so-called S1P drugs, the same family of medicines as Gilenya and Mayzent. It's hoped that this carries somewhat less risks for cardiac arrhythmias, and there's less monitoring that's required in the first dose. But also it should be remembered that because it's in the same class of drugs, there's every reason to expect that it will carry the same risks of basically infectious complications. Fortunately, they're rare, but can be serious. Lastly, the one I'd like to focus on a little bit more is just in August, just a couple of weeks ago, Kesimpta was approved by the FDA, and this is a monoclonal antibody, a manufactured monoclonal antibody known as ofatumumab, that is self-administered, as Nancy mentioned last night. It's self-administered after the first monitored dose. It's self-administered on a monthly basis by subcutaneous injection. It's in the same category of treatments as the existing Ocrevus or ocrelizumab, and some people use generic rituximab off-label for MS as well. So it's in that same category. It depletes the cells that Nancy Sykott mentioned earlier, B cells that are quite important, as it turns out, in the pathogenesis of MS, but also are important in the body's response to infectious agents and vaccines. So it does bring up in my mind, I think, a critical question, which Nancy and others were touching on, which is how safe will it be to start people on Kesimpta, ofatumumab, in the current COVID crisis. One thought that does occur to me is because it is a different antibody that has a different pharmacodynamic effect on the immune system, meaning that in the body, the effects on the immune system are less prolonged, and this is why the treatment has to be administered on a monthly basis rather than every 6 months. Whether or not that fact will not only allow for the obvious convenience of self-administration versus having to come to a clinic for an intravenous infusion, but also the possibility of some more flexibility in dosing schedule, perhaps around the possibility of certain vaccines that, hopefully will be available in the coming months and year. I'd actually like to query my colleagues on the panel. I'm not entirely sure exactly how Kesimpta is going to fit into my treatment paradigm that I'm using now, but I'd like to ask anybody if they intend, for example, to switch people who are already taking ocrelizumab, Ocrevus, to Kesimpta, ofatumumab, and if so, what's the rationale? Does anybody want to comment on that?
This is Howard. We had a lot of discussions. Andrew, I think it's an excellent question, and it relates to the many challenges that we've had, good challenges, because we keep getting new medicines and new things that they fit in. In our discussions, and again, there's no logic or rationale, perhaps, first do no harm. But we would assume that somebody who's on Ocrevus, for example, or Rituxan and doing very well, we would not tend to change them. If they would rather have injections monthly than the infusions, we would respect that. We have to tell them about it. The bigger question I think that you're asking is, what about a new patient who just comes in and
Right.
They ask which one should we take, and then you ask them, would you rather have every twice your infusions, or would you rather have the injections? And then they say, well, what would you do, doctor? We have to be ready. We have to be ready for that. The answer that I would give, one is we don't know. I think when a new drug comes in, we have to be cautious and learn how to use it. And that I would say that we're going to keep the people on Ocrevus and Rituxan, keep them on that, tell them about the new drug, ask them what if they have a preference. I would also tell the group that we have a very interesting study funded by Novartis where we're going to be doing a microglial PET imaging in people on ofatumumab. We've been doing it on some Ocrevus patients, and I think we'll learn a lot to see whether this affects microglial imaging. So Andrew,
I might add, Howard, I just want to interject that your team was funded in their initial research on the microglial PET work by this organization.
That's exactly right. And Nancy, we thank you for that. What Andrew is bringing out, and it's exactly right, is that we are often ahead of everybody else, and we are able to do things quickly because of your funding and your efforts. And this is one of them. This is one of them where you funded a young investigator and people working on microglial imaging. We were able to get some initial data. Of course, you never know whether the experiments will work. They did work. Now we have $1 million grant, a multi-million-dollar grant from Novartis looking at microglial imaging in people on ofatumumab, and it wouldn't have happened without your support. So there you go.
And Andrew, I'll let you just make a brief comment. When we very carefully looked at the new paper, a few points. One, the actual dosing in terms of B cell depletion. Of course, the B cells may be depleted in the blood with ocrelizumab, but what really matters is what happens in the lymph node. And so it's not clear if this new ofatumumab decreased the B cell level to the same degree, certainly where it counts, because it appears to be less in the blood, and that wasn't really stated in the paper. So one concern is a dose equivalent in terms of what it's meant to do. It may be, it may not. Also from a study funded by the Center Without Walls, by Nancy Davis, the paper coming out on September 16th, where we defined the transcriptomic landscape of normal spinal fluid in patients with AMS, the same analysis, again funded by the Center Without Walls, looking at pre-post ocrelizumab is about done. We'll have those data, and we hope to be able to compare whether the immunologic effects of one drug are similar to the other. So I totally agree with Howard. It's a new drug. It may be more convenient for patients, but it may be less so, and time will tell. But we certainly wouldn't switch anyone who is stable from ocrelizumab, and we'll let patients choose until we have more data.
David brings up a good point. If you look at the phase 3 data of the ofatumumab, it's virtually identical to Ocrevus in terms of MRI lesions and disease activity. So it works exactly the same. What we don't know, as David mentioned, is will it affect the CNS as much? And that we don't know. We'd have to see what happens with progressive patients, et cetera.
But there's a possibility also that since it's a fully humanized monoclonal antibody, that there's actually a little less allergic reaction to the drug. So decisions of treatment with patients.
I'll share a conversation I had with the CEO of Novartis when we were talking about ofatumumab coming out, and I said, well, are you worried about ofatumumab and how it competes with Ocrevus? And he said in the history of all drug development in general, a subcutaneous injection is favored by patients and over the long term does better than IV infusions. Whether that's true or not, I don't know, but that's what the head of Novartis told me. Maybe that's just his
Wishful thinking.
marketing.
What did the head of Roche say?
Yeah.
That's exactly. They weren't at the same lunch.
But I think in the COVID era, there is sort of a unique opportunity for two reasons. Individuals who don't want to go to the infusion center and sit there for 6 hours because they're afraid about getting exposed. And
Right.
secondly, again, talking about the vaccine, that if you could, on a monthly basis, have your treatment but be ready to go theoretically, should a vaccine become available, having more, flexibility in that regard. So I think it'll be interesting. I think the other points are well taken in terms of the ultimate effectiveness in comparison to ocrelizumab. And I wonder if Dr. Calabrese had any other thoughts to share.
I do. I was trying to be respectful of time because I know people want to ask questions, but it could cut the other way too. A lot of my patients are concerned about having been on B-cell depleting agents for 5+ years. I know Dr. Cross has some people out to 10 years who are still doing well, but we know from the study from the Swedish group that at 4 years there's an increase in moderate or severe infections. And so theoretically, and this was my hope, was that perhaps a lower dose would allow for sublethal depletion of B cells and might be a little bit safer as a maintenance therapy. And this kind of strategy is used, for example, in cancer, where you come in with a big gun and kill all the cancer cells, and then you allow a little bit of immunity to come back because it's safer. And maybe the B cells that come back won't be as pathogenic. They'll be regulatory B cells. And however, as Howard pointed out, that at least for the first 2 years, the drugs look equal. However, people have MS for a lifetime. And so we need to do these long-term follow-up studies to better understand the relative pros and cons of the different drugs, and agree with what everyone else said.
So are you going to switch people or not?
Well, I'd like to have more data about the drug, but several of my patients have said what Howard predicted, was that they would rather have the control over it and inject themselves than come in for a day to the infusion center, because some of them don't live near infusion centers. It's convenient for some people.
Can I ask you a question? Is it going to be less expensive? And I know that a lot of people on Ocrevus, by month 5, they start feeling not as good. And I was wondering if this helps with it, having it once a month, if you regulate that, if it's a more constant amount of the medicine.
So my answer, as I told you when we spoke previously, is I just don't, at least I just don't think we have enough experience with it yet to know whether that's going to be an issue. I hope with the new drug. Clearly, it does seem to be something that patients complain about with ocrelizumab, but I personally certainly don't have enough experience with it to know whether that will be the case.
And also cost, does anybody know about the cost of this versus Ocrevus? Are insurance companies covering it? Because it might be less expensive or more likely to be covered because it's given in so many doses, and each dose would be less expensive theoretically because they're not having 2 doses per year.
I'm guessing Dr. Weiner's friend at Novartis will know the answer to that, but I don't think we do.
I don't think the cost is going to be different. They always keep them the same cost.
Yeah.
I mean, the same cost per year, but cost per dosage would be
Oh,
less.
right. Yes, likely. Yeah,
It seems
that
like
But the thing is, if there's a cost that when the medication is put on the market is not appearing in the expense, because it depends on the infusion center. So for the medications given as an IV drip, the infusion centers and the time of the nurses that administer the medication can increase the overall cost of the medication. So it's true that having a medication that patients can administer themselves, at least after the first dose, in the big picture, could decrease the overall cost, unless the medication is more expensive than Ocrevus. But we don't have a good idea of the cost yet.
So I think this has been a great discussion, but I in the interest of time, I'm going to finish by just simply saying we still have a lot to learn. and look forward to hearing what Dr. Calabrese and Dr. Weiner have to say about future and emerging therapies.
Thank you, doctors. And continuing the conversation onto emerging therapies and promise for the future is Dr. Peter Calabrese and Dr. Howard Weiner.
Hi, everyone. Hope you're all managing as well as can be expected during these difficult times. And thanks to Claudia for doing a great job, as always, with moderating and setting up this. And a shout out to Liz, who does all the behind the scenes work. But most of all, Nancy, you continue to be amazing. And I echo the sentiment that everyone else expressed earlier about the last night. My daughter, my wife were so excited about the silent auction, and my 13-year-old daughter stayed up and scored some swag, and so she's very, very excited to
yeah,
won a few things. I was very happy she didn't get the last one, but nonetheless, it was really an amazing event. So it continues to be, a sad time, but also an incredibly exciting time in the research world, and I feel very enheartened that all the young people in my lab were so excited when they Johns Hopkins reopened the labs in June and could come back in. They were just chomping at the bit to get back to work. And I know all the other groups' labs are open, and these are the fearless fighters for the next generation. And there are really a lot of exciting things happening. If I could sort of compartmentalize it, there continue to be development of new immune therapies, drugs that target specific immune cells or pathways. And I think there's a great need for this so that we don't over-suppress the immune system, and we can be smarter about targeting the bad cells without killing the good cells that fight off infection. And then we're seeing therapies that are being developed in the category of myelin repair. So I'll talk about that. And then finally, we're actually starting to see some strategies for primary neuron and axon, the nerve wire protection therapies are starting to be looked at in the lab, and plans for the future to translate those into the clinic. So I think probably the most exciting immune therapy that's far along are a class of pill drugs called BTK inhibitors. It stands for Bruton's tyrosine kinase, and this is an enzyme in the cell. It's involved in activation. The inhibitors were first developed for lupus, which is also an autoimmune disease with antibodies and B cell involvement. And it turns out that they look like they're working in MS. And that's exciting because it not only might it target the B cells, but in a different way, rather than just killing them all, which we know may eventually cause too much immune suppression. This may suppress them and keep a damper on them. Interestingly, this same category of drugs also seems to have an effect on microglia, which are some of the resident immune cells in the brain that you heard Dr. Weiner talking about. And if that's true, and if some of the drugs can get into the brain, which it appears they can, then this class of drugs may have a dual effect. It may be able to suppress the very important bad B cells in the blood, but also target some of what we call compartmentalized inflammation in the brain. And that those cells that are in the brain churning out inflammatory proteins may be a major reason why people progress even when they're not having new relapses or new MRI lesions. And this is perhaps the most frustrating category of patients that I see, people who are in their 40s and 50s, they've been on immune modulating therapies, and it seems like things have been dampened down from our traditional outcomes, the relapses and new MRI events, but they continue to progress and accrue disability faster than we would expect for age. And if we can turn off the inflammation in the brain, we think that we may be able to start to suppress some of that process. So the BTK inhibitors, of which several companies are pursuing compounds, are potentially a very interesting class of drugs. With regards to myelin repair, there are about 20 drugs that have been identified in the lab that target pathways that are involved in pushing the precursor cells in the brain to turn into myelin-producing cells. So that's good. They've met with less positive data in clinical trials. It turns out it's been hard either to get the drugs into the brain maybe there are not enough of these precursor cells to make myelin, or maybe the environment in the brain is not conducive for them to turn on in a way that we would like them to. And so we're getting smarter about why the early drug trials have been less positive than we had hoped for. I don't think the studies are all negative. And I think as we refine our hypotheses and understand better how to get these cells to make myelin, we will eventually see that a subset of people with MS will be amenable to remyelination. And that's exciting because it would be the first example of any neurologic disease, brain disease, where we could actually repair part of the brain constituent. So I think we'll stay tuned for that. It's not right around the corner, but like most good things, it will take some time to evolve. And then finally, one of the reasons why remyelination may not work is that if the nerve wires themselves are broken up, there's nothing to wrap the myelin around. And so it is critical that we understand how and why the axons degenerate or crumble, and try to intervene in those pathways at the same time as we're trying to stop the inflammation and repair the myelin. And to that end, a group at Washington University, where Dr. Cross is, discovered a pathway that I think is extremely exciting with a protein called SARM that gets upregulated and actually participates in this axon degeneration. It's almost a pathway that Mother Nature built in so that when axons are so badly damaged that they're not functioning, to help get rid of them, they call it an executioner pathway. But it turns out that in a disease like MS, where you have chronically energy deprived axons, the SARM levels may start to go up, and if you inhibit it, you can rescue them so that you delay the degeneration process, and that provides a window of opportunity to either stop the inflammation or maybe wrap some myelin and improve the energy efficiency of those axons. So I think that's just one example of some of the many new therapies that are coming down the road. Howard Weiner will probably tell us more about the glial cells. His group has been working on microglia, as you heard, and the astroglia turn out to be very important cells that actually people at Dr. Hafler's group at Yale have been studying pathways in the astrocytes, which I think are extremely exciting and maybe amenable to intervention to stop this chronic compartmentalized inflammation process. So I thank you for your, and we'll pass over to Dr. Weiner now.
Thanks, Peter. Great review. Claudia, if I want to share slides, I just do share screen. Is that what I do, or how do I share slides?
Share screen, Howard, yes.
Just share screen.
Yeah, okay. So I'll share screen in a second. I'm going to talk about two things. Number one, we're very interested in the microbiome, the gut, and we're also very interested in we're also very interested in the mucosal immune system. So I'll say a quick word about fecal microbiome transplant, and Manuel may know a little bit about it. We have a protocol in to do fecal microbiome transplant in MS. I think they're doing it a bit in UCSF as well. They're doing it by enema. We're going to do it with pills. We're going to use OpenBiome as a source. We'll probably start with progressive patients. It's been off and on hold by the FDA. So we'll see where that goes. But another very important area in the future, and Emmanuel and I are co-chairs of a conference on the microbiome, is will we in the future be able to modulate the microbiome with specific bacteria to try and help MS? So I think that's a very exciting area for the future. I'm going to share my screen so I can show you just a couple of slides, not a lot, but what we've done with this nasal anti-CD3, because this is going to move into, hopefully move into trials in MS patients. So let's see. Can people see my screen?
Yes.
Yes. So what we've been working on is something called nasal anti-CD3. It's a, I'll show you the mechanism or whatever. We are trying to develop it for progressive MS, and it's moving forward. And since it is Since we do have an IND into the FDA to treat progressive MS patients, I'll let everybody know about it. So this is work that we published in 2016, where if we give nasal anti-CD3, you can suppress the progressive EAE model. Here's a progressive model. They have an attack, and then they progress. And if you treat with the nasal anti-CD3, it decreases disease. The anti-CD3 doesn't go in the brain. It goes into the cervical lymph nodes. And you can see nice protection in the spinal cord. It works by increasing regulatory cells, IL-10 and LAP-positive regulatory cells. And as Peter mentioned, we have very nice data that the nasal anti-CD3 in animals decreases microglial and astrocyte inflammation. And we think that that may be very important. There's just a paper coming out in Range showing that microglia are at the edge of lesions in progressive MS. So we're going to use an antibody called firalimab, which is on the far right. This is a fully humanized antibody. And the company that's sponsoring that is called Tiziana Life Sciences. They're the ones who've made it. And this is how we give it. This is a device. There's something that goes into the device right here that holds the material, and then you put it in your nose, you spray it, and it gives a very nice amount of the material. I didn't do it with nasal anti-CD3, I did it with PBS. And we carried out a phase 1 single ascending dose trial where we gave 10 micrograms a day, 50 micrograms a day, 50 micrograms a day for 5 days of the nasal anti-CD3. And the results are that it was safe. We didn't have any problems. And we saw the immune effects at the 50 microgram dose. We saw some changes in CD8 cells, increase in certain transcription factors. And so we're hoping to move together for a trial in progressive MS. We're beyond the planning stage. It has been submitted to the FDA. Whether we're kind of aggressive, we want to treat people for 6 months. We want to do microglial imaging, and we'll see what they have to say. We're actually giving it as add-on therapy to people who are on Ocrevus because we don't think we can take them off the therapy. But we're very excited about this. Everybody knows how hard it is to, and I'll stop sharing my screen. Everybody knows how hard it is to translate to the clinic, but if you don't translate, there's no chance it'll work. So I'm optimistic, but I'm realistic. A lot of this, Nancy, comes from all the support you've given us over the years and our wanting to one day say to the patient, we have a new treatment. So we're very excited about that, and hopefully it'll move forward in a nice way. So those are the things I have to say.
Thank you, doctors. And now, studying gender difference in MS is Dr. Rhonda Boschko.
Yes,
Dr. Boschko?
Yeah. Can you
I couldn't hear
me?
you. Yeah.
Can you hear me?
I can now.
Okay, great. So I wanted to, again, call out Nancy and the amazing job that she did. I think, you know, people who see problems and find solutions and go outside the box, you know, necessity breeds invention, and people that have incredibly creative minds will come up with a way to find solutions regardless of the circumstances. And I think other people are going to now copy what she's done. And so that's great to, you know, be a trend center not only for MS, but maybe other diseases. And I think that's really a big picture here. Moving on to the thing I wanted to talk about scientifically today, I do want to also share my screen, which I'll do right now.
No, there's no sound.
Are you muted?
I'm not muted.
Oh,
You can hear me now.
Can you hear me?
yeah.
We hear you, but you have to push the share screen, Rhonda, for it to
Yeah, I
work.
did, but
Okay, so maybe, you know,
can you see the screen now or?
now we can.
Okay, cool. Okay, there we go. I guess we're good. You guys can see it? Okay, that's a yes. You can hear me and see it both?
Yes. Yes.
Okay, good. So 6 differences in MS. There are really 2 differences that I want to talk about. And I'm going to bring this full circle actually with COVID in MS at the very, very end. But the main thing here is 6 differences in MS. And as many of you may know, there are really 2 differences. When you talk about susceptibility or likelihood to get MS, females are more susceptible than males are by a 3-to-1 ratio. This is thought to be due to differences in immune responses in the blood, with females having more robust immune responses. But in contrast, which is really interesting and intriguing, I think, is that there's much accumulating data now showing that despite the fact that females are more susceptible, men with MS do worse. And by that, I mean being male is a risk factor for doing worse. The time to progression is shorter in men compared to women with MS. And so this suggests that there's a disconnect between the immune responses in the blood and the brain's reaction to that immune response with its degeneration. And so I think we need to think about 6 differences in the immune system, and also think about 6 differences in the brain as being 2 different things to think about. This is kind of a cartoon of some things you've heard about. We've talked about the immune responses in the blood, and the point here would be that the females would have more overreactive cells than the males would. This is also true for lupus, rheumatoid arthritis, etc. And as discussed, these immune cells can go in and make other glial cells become activated, ultimately resulting in stripping of the myelin from the axons and poor repair, poor remyelination, as well as loss of synapses and axons. So the wires, the connections are damaged, and then they don't repair easily. Now on the MRI, of course, the new lesions, the patients, we all know a lot about the gadolinium enhancing lesions, the new T2 lesions, but really looking, and those are markers for relapses, but gray matter atrophy has been shown a long time to be a good correlate with this kind of permanent disability, not the temporary disability during a relapse, but the kind of disability that accumulates in progressive MS and continues and is slowly accumulating even in the absence of relapses. So really, we're really focused on this gray matter atrophy. So this is a paper that we published last week, and I'm very excited about it because we show that it's not just clinical. There's now a very good way to see this on the MRI. When you look at gray matter, there's worse atrophy in males as compared to females. So this was a collaboration that was done by UCLA with the Charité Hospital in Berlin, Germany, one of the top hospitals in the world. We've collaborated with them for quite some time, and this is the fruit of the labor, which I'm very excited to show. This is the main figure from the paper. We had 134 subjects, 89 MS, and 45 age and sex-matched healthy controls. So we looked at them for gray matter atrophy. Again, the gray matter is where it's really correlating with permanent disabilities. We did it by a couple of different imaging techniques, but the point is that what we found, this was actually pretty early relapsing remitting MS. We obviously want to do this in progressives, but what we found was that in women with MS, as compared to healthy women, there was thalamic atrophy and maybe a little bit elsewhere, but not a lot. In contrast, when we looked at the males, we had the thalamic atrophy, but we also had some atrophy elsewhere. And when you look at the cortex using a different technique called FreeSurfer and looking at cortical thinning, not a lot really early in the females in this sample size comparing MS females to MS normals. But when you went to the males, sure enough, there was some thinning, cortical thinning or atrophy in the cortex. This is important because some of the data show that one of the things that is worse in males with MS compared to females is cognition. And this is an interesting area with respect to some of the networks that can occur related to disabilities. We did go on in the paper and looked at some standard disabilities, and we found some correlations between specific disabilities with specific regions of atrophy in the males and not in the females. And so that's just kind of a snapshot. We're not looking at things as a one-size-fits-all treatment. I think when you think about the immune modulators, you can kind of look at the brain as a one-size-fits-all because you're reducing the immune attacks, and that's indirect neuroprotection. But when you start thinking about treatments to repair, you know, the glial targets. Like we've done a lot of work with astrocytes, microglia. We're looking at repair, synaptic repair. And when you start thinking about those, a lot of gene expression analysis done by our group and others show that these regions are not all alike. They differ, the gene expression differs from region to region and cell to cell. And I think that the way to get a neuroprotective treatment will not be a one-size-fits-all neuroprotective treatment for whole brain atrophy or even total cognition or all the disabilities. Instead, it's going to need to be a more personalized, tailored treatment based on reversing gene expression in certain regions, and that may be sex specific and region specific, which will end up being obviously being disability specific. So disease modifiers to target one disability at a time and optimize in females may be differently than males.
Rhonda, could you put the first slide back on? I just want to look at that reference.
It's the Biology of Sex Differences, which is the journal that was created by the Organization for the Study of Sex Differences. It's the organization I'm the president of, and it's basically.
I see it. Thank you very much.
It focuses on the biology of sex differences.
So can I
was going to finish.
Can I remind?
It focuses on the biology
the panel
of sex differences. I'm sorry. It focuses. Okay, go ahead.
Can I remind people to try to speak lay language when you're talking about data so most people can understand? Thank you.
Sure. Anyway, so this is really important because this journal focuses on the biology of sex differences across all diseases, whether it be MS, Alzheimer's disease, Parkinson's disease, lupus, etc. So speaking of that, there's a lot of interest in COVID in MS, as Ann Cross just gave a fantastic presentation. And I did want to point out that this is a very hot area for the study of sex differences. We're talking to Congress about these sex differences in COVID and what we can learn. And so this is from Ann's data that she just presented on one of the first talks. And as you can see, the incidence or frequency of COVID in MS really is 75% to 25%. And that really just reflects the natural distribution of MS. It's 3 to 1, pretty much female to male. But what was interesting also that Ann showed, Dr. Cross showed, was that the non-survival of COVID in MS was actually 57 to 43. So if you look at the ratio, it goes from 3 to 1 to 1.3 to 1. That argues the same kind of a thing I was talking about, in the sense that you can have a sex difference in the immune response, and then you can have a different response in the lung. And so the idea is now showing that the male survival is worth not just in MS, but also widespread in COVID, is that there are these localized responses in the lung, whether they be resident immune cells in the lung, like as occurs in the brain, or whether they be responses of lung-specific cells, like as in the brain, that are reacting to this damage differently in males as compared to females. And that's all I have. I'll open it up for other speakers or questions.
Thank you, Dr. Boshko. And our last panelist to speak is MS in Children, Dr. Jonathan Santoro.
Thank you, Claudia, and thank you, Nancy, again for the invitation to come speak. And it's very humbling to speak, amongst so many people that I've either been mentored by or have looked up to, as my career has developed. And certainly, I'm the newcomer in the MS field. But what I'll try to do, in the interest of time, is really just talk very briefly about how pediatric MS is a little bit different than adult onset MS, some of the different treatment paradigms that we kind of use, and a little bit of, how we've restructured our approach to care, and then really some kind of more pediatric specific issues that we encounter quite a bit. And I'll also, get into COVID a little bit at the end of that as well. So as you may know, about 5% of all cases of multiple sclerosis will start in children, defined as less than 18. We do know that young patients tend to have more relapses and have more aggressive disease early, and that is manifested in many ways by kind of the annualized relapse rate, or how many relapses you will have in a year. The initial presentations are something that are very unique in pediatric MS and pediatric neurology in general. the first attack can often not be a monofocal neurologic issue. So when I say monofocal, that would be numbness of an arm, weakness of a leg, things like that. What we can see more often in young patients is that they have multiple areas that are all involved at once, or they have multiple areas that are also involved with an encephalopathy or a sleepiness or a change in cognition. And that is often what we term acute disseminated encephalomyelitis, which often gets relabeled as ADEM. And so that in and of itself is very different often than what we see in our older patients with multiple sclerosis. The other two things that we see much more frequently in pediatric patients are clinically isolated syndrome, meaning you've only had one attack and there's been no dissemination in time or space yet. And so in those patients, we will often wait to see what will happen over time, even though we can risk stratify to see who's more or less likely to develop multiple sclerosis over time. And the interesting one that we see much more frequently is something called radiographically isolated syndrome. That's where basically somebody will go for an MRI for another reason. They got into a traumatic brain injury on the football field and got an MRI for a concussion, and white matter lesions were found. And so in those patients, we have a high suspicion that they will go on to develop multiple sclerosis based on what their MRI looks like, but they've actually never had an attack yet. How that is different is that it plays into how many of the inflammatory lesions in young people, because they have larger, healthy brains, can actually have multiple silent lesions that develop before their initial attack. And so when we look at, even in adults, when that initial attack is that brings you to medical care, we often find that there are many other older inflammatory lesions that may be present even at your first attack, leading to, of course, you're talking to a pediatric neurologist, that it's possible that multiple sclerosis starts way earlier than that initial attack that we see. Now, as we know, the brains of younger people are very healthy and they're more susceptible to silent lesion, and that actually changes how disability looks in younger patients as well. There's a publication coming out at the end of September in neurology that myself and Dr. Wabant were part of, looking at what does disability even look like in younger patients with pediatric onset MS. And it's not a lot of motor disability. So between relapses, most patients live completely normal lives or have absolute minimal disability, and this will last for many years, even with multiple relapses. But what we have found is that the neurocognitive piece, or the thinking piece, is often very much affected and missed when we are going through our assessments. So many of our patients will come in and say, I'm having difficulties at school, or I had to be held back, or my teacher said I need an individualized education plan. And all of this will kind of come to fruition often within a few months of diagnosis, which is a lot different than what we see kind of in adults, even though that neurocognitive piece and fatigue are certainly there as well. So when we look at treatments for pediatric MS, thankfully, I know many of my colleagues here were debating kind of, using different new medications. In pediatric multiple sclerosis, we have the advantage of looking what has been out and used in adult patients first, and then kind of cherry picking which ones we think are the safest and which ones might be the most effective. But right now there's only one medication approved for pediatric onset MS, and that's fingolimod. So any other medication is considered off-label, which creates a lot of difficulty in wrestling with the insurance companies and payers, as you guys might be aware. I think that when we look at, and this is something that Dr. Calabrese was hinting at, when we look at how do we treat pediatric multiple sclerosis, knowing that those patients tend to have higher relapse rates, we tend to take the approach of wanting to be aggressive up front. So we not necessarily use an induction model, but we want to give the highest efficacy treatments up front, because we may be talking about 60 or 70 years with a disease process that doesn't have a cure. So we tend to be more aggressive in choosing our treatments. That being said, multiple sclerosis, especially in the pediatric clinic, is a family affair. So at any given visit, we have mom, dad, aunts, uncles, sometimes grandparents, and everybody has a little bit of an opinion. So as a pediatric neurologist, I often end up feeling like I'm an arbiter or a negotiator trying to find the best therapy. But what we do is we choose the best, highest efficacy treatments that our patients are going to be compliant with. The issue has often become, and as all of us were former teenagers, we should all know, telling a teenager that they have to inject themselves 3 times a week. There are some teenagers that are going to be able to do that. There are other teenagers that say, no way, no how, give me any other therapy. And so we really have to take into account what our our pediatric patients' preferences are in the context of what their family is thinking about as well. The other thing that we talk about up front quite a bit is we know that obesity and early onset puberty are risk factors for the development of pediatric MS. So we often will counsel our patients right up front to say, this is a new diagnosis, this is, but we need to actually use a treatment that is a therapy. And then we also need to do things like exercise, change your diet. And we try to lump it in all at once because we find that if we can change those types of behaviors and enforce healthy eating and exercise early on, it's much more likely to continue into adulthood. And as we know, there's not a current cure for MS, and we want everybody to have healthy lifestyles enforced from a very early age. In the days of COVID, there have been a lot of questions, and many of my colleagues here have answered those today. But I think one that comes up quite a bit for our teen patients is, what are we going to do with school? So in LA County, the LA Unified District has gone to a Zoom session, essentially. But in patients who I treat who are from different areas of the country, we have found that the back to school precautions have been quite heterogeneous. And so a lot of the responsibility has unfortunately fallen on our patients, who have to be the primary voice for themselves when they're at school, for enforcing social distancing, having appropriate hand washing facilities, being allowed breaks, wearing a mask, all of those sorts of things. So it's something where we try to impart as much of the duty on our patients and provide them with literature that they can hand out to their teacher, hand out to their principal, and also reach out to the schools directly when we can. It's certainly been stressful, but what we don't know yet, I think, and I think this is the scary thing for us, is there a post-inflammatory phase to getting COVID? And so in our younger patients, we know just from kind of multiple different countries worth of data now, is that young patients tend to have more mild symptoms that are associated with COVID. But what makes us concerned, and something that we've all kind of historically learned about in neuroimmunology and multiple sclerosis, is a viral trigger can reactivate the immune system. And I don't think we've seen that in adults, but in younger patients where there is the possibility that that phenomenon may exist, it's something that we're watching very closely, because we don't want to be fooled into switching therapies for a relapse that may be associated with something that is not the primary MS process. One of the other things that we talk about quite a bit these days with COVID is isolation, as Dr. Kaplan was talking about. Our teens, who are already very well connected with Instagram and TikTok and Snapchat, have actually found excellent ways to communicate and stay connected with their friends. And I think it may have been actually a little bit easier for them in the pandemic age than some of our older patients with adult onset multiple sclerosis. But we've found now that the local support groups for pediatric MS have actually gone to Zoom platforms, and now it's actually incorporating more individuals, which has really been fantastic. And if anyone has questions about how to get connected, I'd be more than happy to answer questions on that. The last thing I'll talk about is, even though we're dealing with teen patients, we talk a lot about childbearing and what are the impacts of these medications in the long term. I never thought I would be talking about safe sex practices as a neurologist, but with my teenage females, we have a lot of discussions about that and what it can look like. And what we take is kind of an open approach. So if our patients don't feel comfortable with talking about that process with me, they can talk about it with my nurse, they can talk about it with our social worker. We have multiple team members who are well versed in these things, but it is an important discussion to have, because life comes and changes very quickly, and we want what we tell all of our patients is, you let us worry about the MS, you worry about being you. And if that includes having children or starting to plan or think about that, we want to make sure that we're supportive of it as well. But thank you so much for that, and I'm happy to answer questions after the forum.
Thank you,
Dr. Santor.
Great.
Now we're on to our lightning round to answer collected questions from the audience. And remember, doctors, lightning means quick answers. So, Emmanuel, Dr. Waban, you have the question.
Yes. So, question. So, Liliana, if you're there, what specifically makes Hispanic males have a worse outcome with MS? Is it attributed to genes, way of life, etc.? Are there any DMT in particular that works best for Hispanic males?
I think Liliana has left us.
Okay, so she was going to come back. So next question for Peter Calabrese. One thing COVID has unearthed is the racial disparities in health outcomes for Black and brown people. While MS affects more whites and non-whites, is it true that African Americans have more active and severe disease? Do you know if there's a shorter life expectancy for Black men with MS? Is there any research program looking at why this is and how to address it?
That's a great question. Thank you for the questions. Obviously really important. Interestingly, when I trained, we were taught that that MS was rare in Blacks or people of color, and it was mostly a Caucasian white person's disease. But that's been revisited and studied from the Kaiser Permanente group and others, and it turns out that there probably is just as much MS in Black people or people of color. Obviously, Liliana has done nice work with Hispanics, both white and non-white. The really critical question is it worse? And several groups have published that people of color do tend to have worse forms of MS, both clinically, and we've been studying this in Baltimore, where about 25% of our patients are Black, and have used imaging techniques, which are very objective, and have been able to show that both the brain and the back of the eye, the retina, using OCT, atrophy at faster rates. And the critical question is, why is that, and can we intervene? And so it's a complicated question that is bounded by social, environmental factors, access to care, inflammation, and propensity for neurodegeneration. We're trying to tease these different parts out to better understand, and it's tempting to speculate that there's a basic biological explanation, but I'm told by my colleagues in cancer research that many of the disparities in outcomes in cancer have been traced back to social and environmental factors. And so we're taking a multi-pronged approach with this. Dr. Ellen Mowry at our center does a lot of epidemiology work. We have DNA and all these folks, and we're working with Jorge Oxenberg and the people in Miami to look at our Black patients with MS and the genetics of it. And then we're also in a position where we have immune cells where we can start to look at the biology of the immune response. And so hopefully we can sort this out and understand why that is. And sometimes, and again, I keep making analogies to cancer, is sometimes the worst cases are the ones where you find a pathway that's intervenable, and some of the worst cancers have been now shown to be treatable. So hopefully we can reverse that and stop that disparity.
Thank you, Dr. Calabrese. So the next question is for Dr. Goodman. I have primary progressive MS for the past 10 years. I'm on rituximab. It doesn't seem to be doing anything to slow down my progression. What would you suggest for primary progressive MS to reverse or change the course of my disease? Has anyone considered any stem cell trials?
Yeah, also a important and common question. And Dr. Calabrese touched on this previously, that even patients with the so-called relapsing forms of MS, despite our best efforts with immunotherapies, they also tend to get gradually, progressively worse. So, and Dr. Weiner decades ago pointed out that that there seemed to be a tendency in people with relapsing MS to converge on a progressive course of MS as well. So this is a sort of an age-old problem with MS, and sadly we don't really have an answer to your question. Rituximab per se is not specifically FDA approved for progressive MS, although it's quite similar to ocrelizumab. That is specifically FDA approved for MS, and what it does seem to do is perhaps in some patients slow down the course of the disease, but it certainly does not stop it or reverse it. So it doesn't make things better. So really what we need, as Dr. Calabrese spoke about in his talk, are approaches that work directly on the level of of hopefully preventing or protecting the nerve fibers, the axons, from deteriorating, and perhaps even restoring myelin, both to help protect them from future damage, but also potentially to restore, to actually restore some function. As to the last issue of whether or not there's stem cell treatments, if by this you mean hematopoietic stem cells or bone marrow transplant, yes, there are studies, and the studies, unfortunately, have not been terribly encouraging for people with more advanced MS and people with progressive forms of MS. So the bone marrow stem cells don't seem to be a very encouraging approach. I'm not saying that there couldn't be individual cases.
Okay, another short question for Dr. Yadav. I'm struggling. Oh, sorry.
Please go ahead.
Sorry, I was. I thought you were done.
It was extended lightning. Sorry.
Question for Dr. Yadav. I'm struggling with hives for months. Can you please tell me if it could be related to MS and my immune response? I'm not on any DMT. If I were to go on a DMT, would this lower my immune response and help with hives?
So I think to our knowledge, hives are not associated with the MS. Most patients with MS do not really have hives. So it could be a different immune condition that you may be having. So the best option would be to see an allergist or immunologist to understand like what, and people can have hives at any age actually. I think it's not just a childhood issue. It doesn't have to be related to the pollens necessarily. So I think it has to be addressed why you're having the hives. And it can be treated very well. We have had several patients, who have it's not common, so it's like, it is, but it's treatable. And the other question was about immunity and MS. Is that Dr. Baba, is that, what was the question about the immune system and hives and MS? So
no, if I were to go on a DMT, would this lower my immune response and help with hives?
No, I think again, depends upon what the hives are. Most hives are allergic reactions, so they do get better with immune suppressive therapies. For example, steroids can help with hives. So it is possible that if you take one of the disease modifying therapy, it may help, but depends upon which disease modifying therapy you're taking. So interferons, I'm not sure they may help with the hives, but for example, like interferon, rituximab or ocrelizumab, which are more stronger immune suppressant, they may help with hives. It's hard to say. I think the first thing is to understand where the hive is coming from and then go from there. So. Dr. Wama, I think.
Thank you. Dr. Cross, what is the best MS? Oh, sorry. Dr. Cross, what is the best MS medication to preserve the immune system function to fight flu and COVID-19?
You're unmute.
Okay, unmuted. Thanks for that question. So the best MS medication for an individual person is the one that works best for their MS. And I would not choose a MS drug based on the response to flu or to any other, to any vaccination or response to an infection. That said, some of our medications, people don't do as well when they get a bad infection. And as someone mentioned earlier, I think it was Emmanuel, Dr. Waba, that the several registries, including the one in North America, are seeming to show a little bit of a trend toward a worse outcome in COVID-19 in people who are on anti-CD20s, which would include ocrelizumab and rituximab and the new ofatumumab. But I personally would not choose a medication based on that hypothetical, but rather on how well it's going to work against one's individual MS. I hope I answered your question.
Dr. Waba, are you still there?
We may have lost.
Thank you. Dr. Heffler, is there Yes, can you hear me?
Now we can.
Can you hear
You're
me?
coming in and out.
Okay, I have some connectivity issue. That's why I turned off my webcam. Dr. Heffler, is there any concern about how quickly the vaccine anti-COVID-19 is pushed through, side effects and so on?
Well, that's an incredibly interesting and political question. I think our hope in the scientific community is simply it will not become an issue. It appears that there is an election coming up, and these issues are going to be politicized. We know that, but rest assured, the medical community is strongly against any political influences. We need to do the pure play. We need to make sure it's safe, because if patients don't view the vaccine as safe, and if the public looks at it in a way that it's not safe to take, then it won't work. And so I don't think we will allow that to happen. And again, let me urge everyone, the vaccines have been around for hundreds of years. They work. They stop disease. We will monitor them for side effects. If there are side effects, that will help determine which ones are used. Let me just one other quick comment about the vaccines. What's interesting is the Moderna approach is using, it's the first time anyone's tried RNA viruses. Rather than making the protein, injecting the protein with an adjuvant, what Moderna is doing is actually taking the RNA from the virus. If this works, and everything suggests, well, this will be a breakthrough in vaccination strategy, because it takes months, if not a good half year, to develop a protein vaccine. It only takes a week or so to develop an mRNA, a message vaccine. So one result, a good result of COVID, if there can possibly be a good result, is developing the ability to make rapid vaccinations based on an approach. We inject the message, which makes the protein into the skin for vaccination approach. But no, I don't think we will allow it as a community to be politicized. And I just hope I'm right. Are you there, Manuel?
Yes, I'm there. I have one of the last questions for Dr. Weiner. Should MS patient receive the flu vaccine? What kind of vaccine, injection versus nasal, single dose versus high dose?
So the answer is that they should take the flu vaccine. They shouldn't take a live vaccine, but they definitely should take a flu vaccine.
Excellent. Dr. Sykott, are there any studies that incorporate 7-TMRI to track progression in Hispanic males that cannot be seen on regular 1.5 or 3 Tesla MRI?
Thank you for that question, Dr. Wabant. So couple issues. There are 7T consortia that are working together, and they're actually part of the NAMES consortia, which was founded with donations from the Race to Race MS. And they are addressing multiple questions related to MS disease progression. I think the ultra high field will offer us opportunities to understand better what the substrate is for progressive MS. And then that, of course, will lead to developing the better strategies and therapies to attack those pathologies specifically. In terms of looking individually at Hispanic males, I'm not aware of any trials that are targeting that. I do see that Dr. Amezcua has returned, and I wonder if there was a previous question about looking at differences in Latinx folks versus others.
Yeah.
You could address that. And also they do have a 7 Tesla unit at USC. I don't know if they're specifically looking at different ethnic groups. I'm going to toss it over to her.
Yeah, so Dr. Amezcua, the question was, what specifically makes Hispanic males have a worse outcome with MS? Is it attributed to genes, way of life, or other? Are there any DMT in particular that works best for Hispanic males?
Thank you very much for the question. I think those questions are very important to answer. So I'm going to start just by saying that studies in Latinx are very small. We have a deficit overall in participation from clinical trials to observational studies. However, now that we have started, yes, we do see that Latinos, Hispanics, they can do worse than whites, even when matched by age and gender. We don't know specifically if males do worse, but I would think that they could be at risk, just like the previous data that we know from just being male with MS. Certainly from imaging, there is some early studies that are starting looking at just Latinos. We do know, of course, from the African American population that when you compare them to whites, there seems to be a lot more degeneration, and there's new data coming out from Darren Acutis noting that. We would like to see more data on the Latinx, but we do suspect that there's multiple risk factors involved in overall MS outcomes that we do need to account for. For example, within the question, the issues are, are the worst outcomes in these populations that usually tend to have less access to resources? Is it an issue that is biological or non-biological? In this regards would be, are there socioeconomic, social, cultural factors that perhaps are not letting them fare better or equal to what we see in whites? And those questions we're trying to answer with, just being involved with very large registries. At USC, we do have one of the largest involvement of Latinos with MS, so I would welcome the participation. And this is, also, sponsored by the NIH, and the early studies that we did have was from Nancy Davis, Race to Erase MS. So certainly we're trying to answer the longitudinal, sort of looking at how does MS in these populations do, and that involves, again, looking at the non-modifiable factors, which are, genetics and some immune measures as well, and as well as the modifiable factors, which would be related to, is it an issue of access to care, health literacy, etc. So we're hoping to have more data soon.
Thank you. So the very last question is for Dr. Voskuil. What is the relationship between Guillain-Barré from flu vaccine with prior onset, between Guillain-Barré from flu vaccine prior to onset of MS?
Well, that's a difficult question. I'm not sure how to answer that. The relationship. Did you say that again? What's the question?
What is the relationship between Guillain-Barré from flu vaccine prior to onset of MS? So basically, is there a relationship between Guillain-Barré and MS onset?
I haven't really seen a lot written about that. Theoretically, you could argue that vaccines could trip off the immune system, and that's clearly noted about Guillain-Barré. But I would be cautionary in the sense that Guillain-Barré is very different than MS. So I wouldn't necessarily extrapolate that. I haven't seen data that Guillain-Barré is a prelude or has a higher association with MS. But maybe I missed that. Maybe somebody else, if you're aware, somebody else on the panel who knows an association between Guillain-Barré onset due to a vaccine, post-vaccine, and MS.
Yeah. Going to say that, just that because the Guillain-Barré is one strain, and it was a very, very slight association. Again, I'm going to be very careful. The side effects from vaccines are very, very rare. And it was a very slight increase in Guillain-Barré with one particular avian flu vaccine, but generally there's no relationship between Guillain-Barré and MS, and no relationship really between the flu vaccine. And we don't know of any worsening of MS with the flu vaccine. And so, the general feeling is the risk of getting flu is much worse than the risk of the MS getting worse.
Thank you, Dr. Heffler and Dr. Voskuil. Claudia, I let you make the final comments. We're through the questions.
Thank you, all of the doctors. I always learn so much from these forums. And in conclusion, we're going to let Nancy Davis say goodbye to us.
Thank you all so much. There's so much information today. My gosh, this year has been kind of a banner year in research. There's so much to report. I'm excited with what everybody's doing. I think MS is quite the popular disease. There's still a lot happening. So excited to have this information, as I'm sure everybody watching is, because there's just a lot. It's great to have this information. We're all very concerned about COVID and having MS. It's really important to know that. I think everybody should just really talk to their doctors. Also, everybody should wear a mask and social distance and just use common sense. I mean, it's obvious that what we need to do. We have to just be smart for ourselves, regardless. And you know, after COVID, there could be other diseases in the future. So it's just a really good lesson on how we have to just be smart and take care of ourselves with just germs and everything. So that's one thing we have to do. It's exciting to see all the different things that are coming up. I love the things going for children and understanding how children get MS and learning about that. I think it's so exciting. And I think the psychological part of this is such an important part. I've heard of so many people being very depressed through COVID. I think that's a very important part to really realize. It's very real. I've heard of so many really negative stories. I think everybody needs to talk to their healthcare professionals and everything, and try not to isolate so much that you don't get out there and become so depressed. So grateful for everybody who supports Race to Erase MS. We couldn't do it without everybody, and we couldn't be where we are without each and every one of you brilliant doctors. You are just the heart and soul of everything. You're making this happen. You're saving so many lives, and I'm so grateful for you. Claudia, you are amazing. You have done this for so many years. You are just an amazing human being. Congratulations to you for always doing what you do. Thank you all, everybody.
Thank you, Nancy.